Okay, so most of you have not met me. I'm Tim Turnham. I'm with the Melanoma Research Foundation. I'm going to say a little bit more about that in a minute. But we are here through the gracious hospitality of the Kimmel Cancer Center, who've made this wonderful facility available to us, and also are responsible for the weather this morning, which we very much appreciate. And good job there. So my role right now is just to introduce you to the director of the Kimmel Cancer Center, who really is the lead person who made all of this possible and us being here possible. So Dr. Pestell, please. Thank you.
Well, good morning, and to the patient survivors, the caregivers, distinguished guests, ladies and gentlemen, on behalf of the 1,250-odd Kimmel Cancer Center members, welcome to Philadelphia for those who are out of town, and welcome to the Kimmel Cancer Center from those who are in town. To me, one of the best parts of this job is to see the values of teams that are thrust together by adversity. And one of the exciting things about this morning, when I look around this room, I can see there are people who have been brought here because they have been affected by this disease, a family member perhaps, a loved one. I can see the caregivers who have a sense of meaning from being involved with patients. And I see some of the researchers and clinicians who are all about finding a solution. So basically we have an army, relatively small army in this room. I see people who are focused on giving hope to our patients, and I see a group of people with courage. So I think, if you look at the importance of what we're facing, melanoma is a very capricious, unpredictable and paradoxical disease. And it's unlike many other cancers in that regard. So it really does require a very disciplined, creative and highly incentivized team to overcome it. And I think those were the key elements that a modern army requires to overcome a formidable foe. And as George Washington said, and thereby procure esteem to all. You've got to love the 18th century politicians. But this is the essential elements of why we will as a collective succeed, because we are together a group of people who have discipline, focus, and creativity, and that is the way in which this disease will be overcome. When I look at this room, I also see a lot of courage. People are dealing with a lot of issues that relate to discoveries that have been made of their loved ones or perhaps of their own. And I just share with you the notion that courage is the lifeline and lifeblood of what we do every day here. Courage doesn't see around corners, but it goes there anyway. Or as John Wayne said, courage is being scared as hell, but saddling up and going out there anyway. And so I think one of the exciting things that for me comes out of a morning like this is that it is a showing of solidarity for the courage of the people who are here today and who are affected in the same way around the country and around the world. And finally, in closing, I'd say one of the great things about these scientific symposiums is they give hope to people. It gives hope to the patient survivors, it gives hope to their caregivers, it gives hope to those clinicians who are looking after patients. And the great thing about hope is it has very specific, unusual characteristics. It sees the invisible, it feels the intangible, and it achieves the impossible. So if I could ask you to rally around these principles of courage and hope, I think that this disease will become history. So thank you for being involved, because the solution is in this room. Tim, can I thank you for being involved? And Sarah, thank you for being involved. And I'll pass the podium to Tim Turnham. Thank you.
So that was a pretty good John Wayne impersonation. So my job is to tell you a little bit about the Melanoma Research Foundation, which I'll do briefly because I know that's not why you came here. I've been the executive director of the Melanoma Research Foundation for 3.5 years. We were started in 1996 by a patient who was diagnosed with metastatic melanoma and cutaneous melanoma, but was appalled at the lack of treatment options. And that may feel familiar to some of you. Diana Ashby, talked to her doctors and said, why don't we have better choices for patients like me? And the doctor said, the only way we'll get there is through more research. So she organized her friends and everybody she could think of and pulled together the Melanoma Research Foundation. Unfortunately, Diana passed away from her melanoma not too long after that, but her husband, Jeff, was a naval pilot and had captained a space shuttle mission, and those kinds of people are not easily dissuaded. So he kept the effort going, and 2 years after we started, we funded our first grant in 1998, $40,000. Our first scientific advisor was from MD Anderson, so Scott from MD Anderson. It's a legacy that goes back a long time with that organization. And since then, we have funded millions of dollars in medical research. We also provide programs like this for patients with melanoma in general, and we do about a dozen of those a year across the country. We have been active in raising awareness and doing some things on Capitol Hill for more melanoma research. And we try to provide a full spectrum of service for people who've been affected by melanoma. Now, when I started, I had a lot to learn and still do about melanoma, but one of the things I learned is that melanoma is not a single disease. It's actually a cluster of a lot of diseases, and several of those diseases start from the skin and are driven by different genetic mutations and different factors. And other forms of melanoma start in other places, like the eye, as you know very well. So when I looked at mucosal melanoma and acral melanoma and uveal melanoma, I was concerned because the melanoma population in general has felt somewhat isolated. We don't have pink ribbons everywhere the way another cancer that we might mention has, right? We don't have the attention that lung cancer has or prostate cancer has or colorectal cancer has. So people with melanoma have felt somewhat isolated, that if you take a subset of that, it becomes an even bigger problem. So what do we do about an isolated population within an isolated population? And tried to explore, are there needs that are going unmet here? And first began looking at doing something in the uveal melanoma space probably 2.5 years ago, maybe even a little bit more, trying to see who was active in that space, are there unmet needs? And I wasn't sure at that time whether we needed to become involved or not, quite frankly. It became clear over time that there was a need that, in my view at least, and in the view of others, was being unmet. So I had the opportunity to meet Dr. Sara Selig, who many of you know, along the way, and was really impressed by her passion, her energy, her vision, her drive, and her ability, more than anything else, her ability to get things done. And so when we thought about doing something in the uveal melanoma space, Sarah's the first person I thought of. And so it's been a few months now since we got this started, the CURE OM program. And Sarah's going to tell you more about what's happened in those few months. But I want to talk more generally and very briefly about what we hope to achieve. And not so much in the CURE OM program, but generally what we hope to achieve. And it's basically this. We believe that every patient needs and deserves good treatment options. And so we will continue to fund research and to push for more federal funding of research that will help make that possible. I'm very pleased that we have in the past funded research that's relevant to uveal melanoma. We are currently funding one of the leading voices in uveal melanoma. And we have just had an RFP, a request for proposals, for a uveal-specific grant. I'm very, very pleased about that. Patients deserve to have treatment options that work, and the only way to get there is research, and we want to make that happen. Patients deserve to know what those treatment options are, because all the treatment options in the world don't help if you don't know about them and you don't have access to them. We're seeing this right now in the cutaneous melanoma field, where 2 drugs were approved last year for cutaneous melanoma, but a lot of patients are not being offered it because their doctors don't know about it, aren't familiar with it, and aren't offering it to their patients. That's not okay. Patients deserve to know that they are not alone, and they don't have to walk through this journey by themselves. They deserve to know and to feel the strength that comes from numbers, from when groups like this come together. And I loved last night, a few of us were around for a little informal meeting in the lobby of the hotel. I loved seeing the hugs that I saw shared across that. And a lot of people who had known each other for some time on Facebook, but were meeting for the first time in person. And it was like coming home. And that's the way it should be. I am convinced, and this underlies everything we do, that patients who are well informed and well supported live longer and better. It's not a promise that you'll live forever, but none of us has that promise. But you can live longer and better by being informed and by being well supported. If at the end of this weekend you leave from here with information about your cancer that you didn't have before, if you leave here having met a few new friends or strengthened a relationship with an old friend, and if you leave here with new hope, then we've done everything we could possibly imagine doing. So that's our goal for the next 2 days, and I hope that that goal becomes a reality for each of you. I'll turn it now over to Sara.
Thank you, Tim, and I get emotional just looking out. So if any of you were worried about crying today, I'll just start us off so no one else has to feel weird about that. But I guess I want to start with just some thank yous. Thank you to Tim and the MRF for taking us as part of the MRF family. We're all a part of the MRF family now, and I think that it's been really courageous of the MRF and Tim to be so dedicated to the uveal melanoma community. So I just want to thank Tim and the MRF again for that. Thank you again to the Kimmel Cancer Center, Thomas Jefferson University, all our speakers and volunteers for helping to make this possible. It's been a labor of love for a long time. We really are grateful to all of you. Thank you to our sponsors for helping to make this possible. And the big thank you is really to all of you sitting in these seats for traveling from all over the US, Canada, the UK, to take a risk and come see what this weekend is about. This weekend is for you, so I hope that you will give us feedback. There are surveys in your folders. We want to know what you think. We want to know how we can be better. So please, open dialogue and communication. We take the C in CURE OM, community, very seriously and really want to know that we're meeting the needs of the community. And on that note, I have a few slides, kind of the nuts and bolts of CURE OM, which we can go through kind of quickly and we can talk about more through the weekend. But a couple highlights that I want to hit before we do that is that we're all in different sort of emotional states, as you can see from mine up here. So we want to make sure everyone feels comfortable wherever you are and supported wherever you are, wherever that may be. And we have a few things that we've put into place for the weekend to help with that. We have social workers who are going to be leading breakout sessions. And if any of you are in the room right now, maybe you could stand. I'll read off some names. We have Greg Garber over there, Bonnie Dalzell. We have Bonnie, I'm going to butcher these last names, but Kruthamel. Is she here yet? Maybe not. Allison Pitok. Susan Walther stood up already, thank you. Sunny Lee Park, and Ruth Feinblum. So these are social workers who are going to be, at least several of them will be with us throughout the entire meeting. Always available. If you're feeling overwhelmed, if you're having difficult feelings, if you need to leave the room at any point, feel free to. You can tap one of those folks on the shoulders. And they're there for us. I also wanted to highlight our patient panel, who has been willing to be sort of buddies for the weekend. So if you feel like you want to talk to somebody who's been there before, maybe not a social worker, I just want to introduce our patient panel briefly too, so you know who those people are. So if you wouldn't mind standing up. Tanya Cabral, Dan Larkin, Carissa Katzenstein, Michelle Oatley, and Sarah Elizabeth Ferris. So, so you'll see more of all of these people later, but I just wanted you to know that we have people sitting here who are ready and willing to help, and Tim and I too. Any of us, I think anyone in this room could be tapped on the shoulder and, can talk if need be. So that, just first and foremost, in feeling community and connected, I just really wanted to make that point first and foremost. So I will go through these slides rather quickly, and like I said, we can touch on topics or questions that you have later, but we'll get through this so we can get on with the meeting. And Tim gave a really nice introduction to CURE OM. So we've now been around for about 8 months, and this is just sort of the outline that I'm going to try and hit on these points. So I will just give a brief introduction of myself, and I probably will get emotional with this, but for those of you who don't know me, I'm an internist in Boston, but got involved with uveal melanoma for a very personal reason. When I was a fourth-year medical student, my husband, Greg, was diagnosed with the disease. He was 34 at the time. And it was really through his journey that I learned a lot about uveal melanoma, and that we got involved in the field, trying to organize and make things better for us and for everybody in the community. After a long, hard battle of 5+ years, Greg passed away in January, about 5 months ago. But he would want us to be here today, continuing the fight. He had so much hope for us and for all of you, and I think that we can realize his vision and dreams as a community. So that's how I got involved. The CURE OM mission, as we formed the initiative in the fall, is to support research and accelerate the development of effective treatments and ultimately a cure for ocular melanoma through innovative strategies, including international and interdisciplinary collaborations, to improve the lives of people affected by ocular melanoma by creating systems and programs to provide education and support and to advocate for the ocular melanoma community. We have 2 steering committees that are generally guiding the initiative. One, a patient and family steering committee, and you can see the members here. We can have them stand up maybe at lunch and talk a little bit. We can give them a thank you then. Represented by locations New York, Massachusetts, Ohio, Texas, and the United Kingdom. So we started small. We hope to build it over time, and it will be a rotating body of patients and family members. We also have a scientific steering committee specific to the CURE OM initiative, and this is made up of 15 individuals who are all experts in uveal melanoma from a variety of different disciplines, as you can see outlined on the slide, and from several countries. The US, France, Israel, Germany, and Sweden are all represented on the steering committee. And it's led by our co-chairs, Keith Flaherty, who's a medical oncologist at Massachusetts General Hospital in Boston, and Bill Harbour, who's an ocular oncologist at WashU in St. Louis. So the research initiative, in addition to the steering committee, we have a contact list of about 170 physicians from around the world, a really interdisciplinary group, represented, a similar representation as our steering committee. We just held our first semi-annual scientific meeting, May 4th, in conjunction with one of the largest ophthalmology meetings in the world, called ARVO, and we'll hear from Dr. Scott Woodman. He's going to give us an update from that meeting shortly. And we have 2 additional meetings planned for November, and then again next May. And as Tim mentioned, we've also announced our first uveal melanoma specific grant. It's an established investigator award at the level of $200,000 over 2 years. We received 18 proposals from around the world for this first grant, and we're in the process of reviewing them now. We use a peer-reviewed process, so experts in the field will rank the proposals and help us decide which ones are the most important science in the field to fund. That's the process we're undergoing right now. And we're also working very hard to build collaborations with other organizations, and one particular organization is the European Rare Cancer Initiative, the uveal melanoma group. We think that this is a really important way to fast-track clinical trials if we can help build collaboration. Patient and caregiver initiatives that we have initiated. Many of you have seen the CURE OM website. We try to keep that as up-to-date as possible, and we have specialists review it periodically. we're all at the first annual Eyes on a Cure meeting, and we have our second annual meeting scheduled for March 1st through 3rd. You all should have a save the date in your folders. That's going to be at MD Anderson Cancer Center in March. Our hope is to move the meeting around the country to capture different locations, and hopefully we'll be able to come back to the Kimmel Cancer Center in future years. We're also in the process of launching a patient education webinar series. We don't want to see you once a year and then leave things for the 11 months in between. So about every 3 to 4 months, we're going to be planning educational webinars with experts that you can watch at the time and ask questions during the time, or they'll be up on the website afterwards. And we have different topics. We've taken polls on Facebook and other places to get information from patients about what you want to hear. And so we'll be announcing those shortly. And our first one will likely be the end of July or beginning of August. So stay tuned as we announce that. And then other support systems, as Tim mentioned, we have an online patient forum. We have a buddy program. We have several uveal melanoma patients in the buddy program, a clinical trials finder online, and a helpline. So lots of patient supports within the MRF. I'm going to briefly just hit this just to let you know that at many different levels we're working very hard to fundraise to not only be able to support everything we're doing, but to grow the program. I'm not going to go through all of this individually, but I just wanted to let you know that we are working very hard at different levels to be able to bring in additional funding. And close this part with future directions, and most of the top ones I've actually covered, so I'm just going to start about towards the bottom. We're hoping to, later this year, develop a community physician education series as well, to educate physicians who are not necessarily affiliated with some of the uveal melanoma centers, but we want to get education more into the community, information more into the community. And then we want to continue to support and enhance research collaborations and collaborations for clinical trials. And then lastly, and I put this in bold because I think Tim and I both feel like this is really, really important, and particularly for this weekend, is we want input from all of you. I'm sort of putting this up here, not because, oh, look, we're so great, but this is kind of what we've done, and we need your input on what we should continue doing, what we can do better, what we should change. And so I really think in future directions, that's really the most important item, because you will lead us forward. So I'm going to end on this slide, and I'm going to read something which I hope I can get through. I wanted to read just briefly what my husband Greg spoke at the first patient meeting we were involved with in Boston in 2010. So I probably won't be looking up much, and I'll try and get through this, but I thought it was a really good note to kind of lead us into the meeting. Greg was a psychologist by birth and by training, and just really valued collaboration and community and bringing people together. And I think in these words, it really outlines that, and I hope that we can all feel that as we move forward into the weekend. So this was Greg in 2010, so 4 years after being diagnosed and after 3 years of living with Mets. It feels so good to be here this morning, to be with you, for all of us to be together. I remember first being diagnosed 4 years ago, and I remember feeling terribly alone, largely due to the fact that ocular melanoma affects so few people globally each year. I remember explaining it to friends using statistics like 1 in 6 million in my age group per year gets diagnosed with ocular melanoma. And over the years after my initial diagnosis, I remember countless times when I felt alone. I would speak the words ocular melanoma to my friends and others and was typically met with reactions like, "What's that?" or "I've never heard of that," or "It's just eye cancer," or just silence. Possibly the same reactions I would have had if someone talked to me about ocular melanoma before I was first diagnosed. Now I've had wonderful support around me over the past 4 years, from my wonderful wife, my family, Sarah's family, our wonderful friends, amazing love and support, truly amazing. Yet still, there has always been a feeling of loneliness that for me has something to do with the fact that this disease is so remote, so rare, so off the radar of many people's thinking, even at times for those who treat us. Coming into this weekend and coming here this morning, though, things do not seem so rare to me, so unknown or so foreign. Instead, I feel at home and so comfortable in many ways. For the first time ever in the past 4 years, Sara and I and our families are amongst so many who truly understand what we are going through. We don't have to be met with looks of confusion. You understand. We understand each other. With this meeting and the events that will unfold over the next few days, the series of doctors' meetings that have now taken place and will continue to take place, and the many collaborations these treatment providers and researchers have formed, I feel ocular melanoma is becoming bigger and receiving more attention. It may still affect the same amount of people per year, but in many ways it feels to me that there is momentum, an energy, a connection, and community building amongst treatment providers and amongst all of us. This community, this coming together, not only feels so wonderfully supportive to me, to all of us, but honestly, I feel in the end, this is what it's going to take to put an end to this terrible disease and find a cure. I'm really looking forward to getting to know all of you over the weekend. Thank you for being here. So with those words, I think we can enter into this weekend with that sense of community and that hope. And I will just thank everybody again for being here and introduce our first speaker, who is Scott Woodman. Thank you. So, do you want to, I'll introduce you. Do you want to pull your, So Dr. Scott Woodman, for those of you who don't know him, is a medical oncologist at MD Anderson Cancer Center and is specializing in rare melanomas and attended our recent scientific meeting and is going to give a brief update from the scientific meeting that just happened in May. And then you'll hear from him a little bit later on targeted therapy as well. So thank you, Scott, for being here.
Thank you, Sarah. First, let me just say that it's a real honor to have been asked to speak to you all. I was at the event that Sarah organized 2 years ago for patients, and I go to a lot of meetings, a lot of scientific meetings, and by far that was the most meaningful meeting to me because I got to interact with all of you. And as a scientist and a physician, it was a very powerful experience. So I'm very happy to be asked to be back to speak to you all. I also want to say to Sarah, we've developed a relationship over the past few years, and Greg was a very special man, and we miss him dearly. But he and Sarah had a vision, and this is that vision. And by having these scientific meetings that they've had, it's brought us together, a community of scientists and physicians, in ways that we wouldn't otherwise come together, even though we have meetings. And I have had more of my collaborations blossom from those meetings than any other meetings that I attend. So thank you, Sarah. I'm going to kind of flip around a little bit because I love to use the pointer. And great. I think can everybody hear me okay? Okay. So I have a little bit of an ominous task of presenting some of the features of the scientific meeting that we had on May 4th. Ominous because I realized that to tell you what we discussed, I'd have to backtrack and sort of do a biology 101, cancer 101 primer. Not because you all aren't smart folks. You guys know a lot more than a lot of folks out there. But I just want to make sure everybody's at the same level so that we can talk about what the really salient features of the meeting were. So number one, I'm going to talk about GNAQ and 11 mutations, what they are, and potential approaches to therapeutic development based upon knowing what they are. BAP1 mutations, what they are, and potential approaches to therapeutic development given what we know about them. And then, as Sarah mentioned, the International Rare Cancer Initiative, what it is, and potential benefits that may derive from its existence. And at the end, I just want to leave room for questions on anything I discuss. So the scientific meeting had these speakers and many other scientists as well, but I just wanted to recognize them. Hans Glasnikos, myself, John Sondek, Frank Rauscher, Dr. Hody from Dana-Farber, Takami Sato, who you'll hear from later, Vidas Mali from my institution, MD Anderson, and Rich Carvajal from Memorial Sloan Kettering. A lot of what others will talk about today was talked about at the meeting by these individuals, and I have to say that the meeting was well attended by both U.S. and international scientists. So it was really a great meeting. Oh, did I go? There we go. Oh. Okay, here we go. So the key gene mutations in melanoma are really 3 that we know of. Mutations that occur in the gene GNAQ, mutations that occur in the gene GNA11. 85% of all uveal melanoma tumors will have a mutation in either this gene or this gene. They are mutually exclusive. If you have a mutation in Q, you do not have a mutation in 11. If you have a mutation in 11, you do not have a mutation in Q. And the mutations that occur in these genes are activating mutations. They make the product of that gene, which is a protein, much more active, oncogenic, to make that tumor grow and survive and become cancerous. BAP1 gene is present in 85% of uveal melanomas that will metastasize. And the mutations that occur in BAP1 are deactivating mutations. They turn off the gene, and you might say, well, turning off a gene might be a good thing, but not when it's a tumor suppressor. So the normal function of BAP1 is to keep the cell from becoming a tumor or a cancerous cell. And so when you get mutations that deactivate that function, it's a double negative. It creates a situation where you get growth and survival and metastasis. So now I want to backtrack to my Cancer Bio 1 primer so that we can talk more about this. So chromosomes are the way that cells bundle DNA. So here's a chromosome. Chromosomes live in the nucleus of a cell. And you have 23 pairs of chromosomes in a normal cell. Right here, you get 1 from dad, 1 from mom for chromosome 1, same thing for 2, 3, onward. And this one happens to be a female because there's 2 X chromosomes, 1 from mom, 1 from dad. So chromosomes are ways to bundle DNA because they have to be in a small space in the nucleus, but they can be unraveled, and when they're unraveled, they end up being a linear string of molecules. Okay, so what is DNA? It's 4 different molecules designated as A, C, G, or T. The human chromosome contains 3.2 billion of these A, C, T's, and G's. What is a gene? Is a particular sequence of A, C, G's, and T's that's specific. So it's almost like the number in if you had a telephone book that represented all your chromosomes, each phone number in there would be distinct, and that would be like a gene. It's distinct because of the sequence of numbers in the case of a telephone book. And genes are distinct because of the sequence of A, C's, T's, and G's. And each human cell has about 23,000 genes, and a gene is the instruction set of the cell to make a protein. So here's your example. You have a ball of yarn, which represents that chromosome. You unwind it, and you get this linear A, C, T's, and G's sequence. And that particular sequence, starting A, G, T, C, C, so on, is gene 1, and it instructs the cell to make insulin, for example, which is a protein. Same thing with this gene, different sequence of A, C, T's, and G's, and it instructs the cell to make GNAQ, and so on. Same with BAP1, and so on, for 23,000 genes, okay? Now, cancer is caused by changes in DNA. So here's the normal that we just saw. But here in cancer, when you look at that string of A, C, T's, and G's, there's been one change. What was a T in the GNAQ gene is now an A, for example. That one change means that this protein is different. And in the case of GNAQ and GNA11, that one change makes it on all the time. Okay, is that clear? So GNAQ and GNA11. So GNAQ is a protein that sits at the membrane surface, and under normal conditions, you need an external signal to a receptor that lies in the cell membrane. This is the cell membrane. This is the inside of the cell. And so that external signal triggers the receptor to release GNAQ, and then GNAQ signals in all these ways to tell the cell to do something. Grow, survive, migrate, lots of different functions that cells can do. The problem is when you have a mutation in GNAQ, you don't need the external signal. So you don't even need the receptor. It's on all the time. And it's telling the cell to grow, survive. So it's what we call constitutively activated because of the mutation. Okay? Well, with other genes in other cancers where you have activating mutations, there are drugs that can specifically inhibit them. BRAF, you've heard about probably. If you have a BRAF mutation, there's a drug that inhibits BRAF mutant tumors. You have a KIT mutation, there's a drug that inhibits KIT mutation tumors. Unfortunately, with GNAQ and GNA11, the situation is different. It's hard to target GNAQ and GNA11, and here's why. If you grasp this concept, I think it will explain to you why it really is difficult. So in the inactive state, it's sitting at the membrane, as I mentioned. It has two phosphates. When an external signal comes and activates GNAQ or 11, it gains a third phosphate. It's in the active phase. But the molecule has what's called an intrinsic GTPase, which is represented by the scissors, which recognizes there's a third phosphate and cleaves it, so you're back in the inactive form. This is the intrinsic GTPase is the mechanism by which it knows to shut off the protein. In the case of the mutant protein, the intrinsic GTPase is not functional. The mutation makes it not functional. So that's what was represented here by the scissors not having their ends of their shears. So you can't cut off that third phosphate. It's on all the time. Okay? So what would you do if you were a drug company or a scientist and you wanted to reverse this process? You'd have to make intrinsic GTPase functional. You'd have to somehow change it so that it's functional again. And that's a very difficult pharmacological problem to do. Very different than BRAF, very different from KIT and other types of molecules. So what do we know about GNAQ? This is another way of representing the molecule. Well, we know that it has binding partners, Rho-GF and PLC beta. It has others, but these are probably the two most studied and understood. And what came out of the meeting, and John Sondek from UNC is the one who really presented this data, is that these two molecules that are downstream, meaning that when GNAQ is activated, they get activated and then signal to the cell and to tell the cell to grow, etc. These two proteins engage GNAQ and 11 using essentially identical interactions of what's called a Helixturnhelix. So the way I think about this, and sort of, when I step back from it, is that if GNAQ is a lock, the key of PLC to bind it and the key from Rho-GF to bind it are essentially the same. So John Sondek's thought is, well, what if you could mimic the key, the part of this molecule, that bind GNAQ? And so he made peptides that were Helixturnhelix peptides, and they can competitively inhibit the interaction of GNAQ with PLC beta and Rho-GF. And so you might say, well, that's great, because now you could inhibit this interaction, and since this is on all the time because it's mutated, the GNAQ, GNA11 on all the time because it's mutated, you could just essentially inhibit its interaction with both these molecules with this mimetic. And that's worth trying, and I know he's going forward with that. But the problem there is that peptides historically are very difficult molecules to use as therapeutics in this sort of setting. So one other way, sort of a out-of-the-box way of thinking, is to say, well, let's use that peptide in cell lines to put it in there, so it's binding to GNAQ or 11 like it should, inhibits these guys from interacting with it. But we'll do a screen with thousands and thousands and thousands of drug compounds and see if we can displace this peptide from binding to GNAQ and GNA11. Because if you find a drug that can displace the peptide, you now have a good drug binder to GNAQ or GNA11, and drugs we know how to use. Much easier to use than a peptide. Okay, and that's what this represents. To use a peptide to use for high throughput screening of inhibiting GNAQ and 11. And that's John Sondek work at UNC. So very powerful work. BAP1. So I told you, BAP1 is mutated in 85% of primary uveal melanomas that will ultimately metastasize. What does BAP1 do? Well, in order to understand BAP1, you have to understand monosomy 3. So I'm sure all of you have heard the term monosomy 3, but what does it mean? Well, again, we're back to looking at all the chromosomes, and monosomy, mono 1, right, somy chromosome 3, you've lost one of your chromosome 3s. So a tumor that has lost one whole chromosome 3 is called a monosomy 3 tumor. So Bill Harbor's group looked at the remaining chromosome 3 and found that it had a gene called BAP1 that was mutated at many sites. This is BAP1 gene, and every one of these little dots underneath it represents a particular mutation. So lots of places in the gene can be mutated. And when it's mutated, it's not functional. So you've lost the function of the BAP1 that was on this chromosome 3 because it's no longer there, and you've lost the function of BAP1 on the remaining chromosome 3 because it's mutated. This is called a loss of heterozygosity, just in case you hear that term. So now you have dysfunctional BAP1. I told you BAP1's a tumor suppressor, so if you lose a tumor suppressor, you have activation, right? Well, now, what does normal BAP1 do? Because if we understand what normal BAP1 does, maybe we can do something about it. So I told you that chromosomes are ways of bundling DNA, and the way they bundle it, you can't read the word here, is the use of proteins called histones. And histones are represented here by all these colorful little proteins here. They essentially entangle the DNA, roll it up into little balls. And so these are the histones. Here's the DNA double helix, and so on. Well, these histones can be modified by other proteins, and represented here in yellow is ubiquitin, and it's binding to a histone called histone H2A. And the reason that's important is because the role of BAP1 is to remove these ubiquitins off the histone H2A. Why does that matter? Because what histones do, since they bundle the DNA, if you take the ubiquitins off, they sort of release the DNA, put it in a different conformation. And when it's in a different conformation, different genes get turned on. So one way to control how genes are turned on and off is by putting the DNA in a different conformation, and the histones do that, and you can modify the histones with these other molecules called ubiquitins. And because BAP1 just takes these ubiquitins off, just imagine this one comes off, this one comes off, this one comes off, and this DNA all of a sudden sort of unravels a little bit. And when it unravels, whole sets of genes can be turned on. And so here, this is to represent the fact that when you lose BAP1, you no longer can take off those ubiquitins. So you stay in this closed histone state, resulting in unfolding of DNA and gene activation is what BAP1 usually does. So now you can't unfold the DNA and you lose that gene activation. Okay, does everybody kind of get that concept? Okay, I have 5 minutes, I'm told, so I'm going to quickly go through the rest. BAP1 is part of I told you it's a tough task. BAP1 is part of a complex that I just showed you here. It's sort of in a complex of molecules. And what Dr. Rauscher from the Wistar Institute here in Philadelphia showed us is that metastasis suppression in uveal melanoma requires a certain domain on BAP1, this domain, this part of the gene. That BAP1 UCH function does not work in the absence of another molecule called ASXL. When you have ASXL with a normal BAP1, it heightens the function of BAP1 by 100-fold. This is the enzyme activity. And mutations, as you can see, can happen anywhere in BAP1, and some of them happen in the enzymatic site, like this one, this one, this one, this one, this one. Other ones happen down here in the C-terminus, we call it, which affects its binding to ASXL. Well, I just told you that you need ASXL to make BAP1 really functional, so if you can't bind it, it's going to make it less functional. And so how do you solve this problem pharmacologically? And so what Dr. Rauscher is doing in his laboratory is saying that depending on where the mutation occurs, it may be possible to reactivate BAP1. If the mutation occurs in the enzyme, it's going to be very hard to reactivate it. But if it occurs in where it binds ASXL, then potentially you could make a mimetic of ASXL, a like molecule, and allow for BAP1 to regain some functionality because it's not binding well to the normal ASXL. And so that's a very keen concept. So both of those concepts, Dr. Sondek and Dr. Rauscher, are coming up with novel ways to essentially turn back the mutation of GNAQ and GNA11 or BAP1. And those would be novel therapeutic ways of approaching the disease. Finally, I want to end with the International Rare Cancer Initiative. The objective of this initiative is to design and fund clinical trials of treatments for rare cancers. Uveal melanoma is now included in that group, thankfully. It consists of the Cancer Research UK, the UK National Cancer Research Network, the European Organization for the Research and Treatment of Cancers, National Cancer Institute here in the US, and Memorial Sloan Kettering, Richard Carvajal is representing, but this is a big group. And at ASCO, our big cancer meeting, this group met, and many, many, many other folks, including MD Anderson and other cancer centers, are part of it. And it's anticipated that there may be a trial using MEK, which I'll talk about later in our targeted therapy section, and MEK plus AKT. And a lot of what I talked about here is you're going to hear over and over again, so don't worry if you missed things, because a lot of the talks are going to be talking about BAP1, GNAQ, GNA11, and their role. So I thought this would be a nice primer for talks that will follow mine. Thank you very much.
The question was whether the copies of the slides can be made available. Yes. All right. Thank you.
We will try, as long as the
Yeah, if
speakers are okay with it,
everybody's-
we'll make copies of the slides available.
I'd be happy to share the slides with everybody.
We have time for questions. Yeah, why don't you do that? I'll run up there.
Oh, I think we have one right with a microphone there.
We are so privileged to have Dr. Shields and Dr. Shields with us here this morning. I'm sure many of you have been treated by them and know how wonderful they are. So thank you so much for being here with us today. And I will turn it over to you. I push laptop. Do you want to wear? No, okay. Okay, and here's the pointer. Thank you.
I want to get it up on the screen here, though. Bring it up here. Yeah, this way. Okay, yeah. Thank you very much, Sarah. It's a pleasure for Carol and me to be here. I know a lot of the people in the audience, and it's a pleasure to see you back and see that so many of you are doing so well. I think this is a great program and one that's going to be beneficial to patients, especially to doctors, researchers, etc. I have no proprietary interest in the material presented here. We come from the Ocular Oncology Service at Wills Eye Institute here at Jefferson, and there are 5 of us in our practice that concentrate doing full-time ocular oncology. We also have 1 or 2 clinical fellows at any given time, and we usually have 4 to 6 international fellows. And we now have approximately 80 ex-fellows who are in every continent except Antarctica, and they're all running ocular oncology services in many of their centers around the world, and we're proud of that. We see only patients with uveal melanoma and other ocular tumors, and in our practice, we see between 8 and 12 new uveal melanoma patients each week, and many other tumors as well. And because of that, we now have more than 14,000 excellent charts on patients with uveal melanomas that can be used for retrospective research, and I think hopefully with funding in the future, more important research projects will evolve from this database that we have. First, a comment about what is a uveal melanoma, and my topic is to talk about mainly diagnosis, how we recognize it. But it's important to point out that the uvea, and you're all using this term it seems, what is the uvea? It's a layer of the eye that consists of 3 parts: the iris, the colored part of the eye in the front, the kind of hidden ciliary body, and then the extensive choroid beneath the retina. This is not a retinal melanoma. Many patients and many doctors too will say, oh, we saw your patient with the retinal melanoma, and that's incorrect. It's not the retina, it's the uveal tract. And there are 3 components to the uveal tract: the iris, the ciliary body, and the choroid. And melanomas can arise from any of these. First, let's say something about pigmented lesions of the iris. Very commonly, and many of you have these, is the iris freckle. It's a small spot on the iris. It probably has no malignant potential, and we don't worry about it. But we see occasionally an iris nevus, which is larger and occupies a greater portion of the iris and destructs the superficial portion of the iris a little more. Of these iris nevi, about 5% do grow and possibly evolve into melanoma after 5 years, but the most of those are so benign that they can be followed. Iris melanoma is more recognizable as a larger growth. It can overhang the pupil. It can invade the so-called angle of the eye and produce secondary glaucoma and other changes. It is malignant and needs treatment, but generally offers a better prognosis than those further back. The second component of the uvea is the ciliary body. The posterior uveal melanomas comprise either the ciliary body or the choroid. Let's look first at ciliary body melanomas. You know, they're usually pigmented ciliary body mass that's in an occult location. We can't see through the iris, so you're not going to recognize it. And hence they can attain a very big size, unlike iris lesions, where they're not recognized until later. But we teach the ophthalmologist that there are certain features by looking at the outside of the eye without looking in that you can recognize an underlying melanoma of the ciliary body. The first is this peculiar dilated blood vessel that we call a sentinel vessel. If that occurs, it often means there's an underlying melanoma beneath the sclera. Second, some of these actually extend through the eye, through the sclera, and form a nodule on the surface. That's called extraocular extension. That imparts a worse prognosis, but these are external signs that we teach. You should then dilate the pupil widely and look carefully through the dilated pupil, and you'll see the tip of the melanoma back behind the iris in the ciliary body. This enucleated eye here, showing a section of a melanoma, depicts that very well. This tumor is very big in the eye, covering about 1/4 of the eye. If that same tumor were in the iris, it would be recognized years before. So it is important that they do get larger. Now we'll venture posteriorly and say a few words about those in the choroid, the back part. We're going to talk about the clinical features and how we go about making the diagnosis on a patient that may have this. The clinical diagnosis, most importantly, is by doing a good eye examination, do an external examination, slit lamp examination, and then look at the retina, the fundus, with ophthalmoscopy, and then we can do ancillary studies. We can recognize many of these melanomas because it's an elevated pigmented lesion that for us, when it looks like this, is a split-second diagnosis. We recognize it, there's not much else that looks like that, and we know what it is. To talk about melanomas, though, we should mention the precursor of melanoma, and that's the nevus. The choroidal nevus is really common. It occurs in about 5% of the population. It's a smaller, flat, or minimally elevated lesion beneath the retina, and these are benign. We see them every day, and they can usually be followed for signs of growth in the future before we recommend treatment. The choroidal melanoma, however, is different. It's usually larger when it presents, and a patient with a melanoma in the choroid will show this elevated dark mass. It has this very typical orange pigment, as we call it. Some of you know we've talked about that in your presence. Sometimes as the melanoma gets larger in the eye, it can begin to bleed and produce actually a mushroom shape, which is actually very typical of a melanoma. Now, sometimes melanomas can be tricky. You know, it's a pigmented growth, but sometimes they're totally white without pigment. And that's when it's a little harder for us to recognize. But we can do a number of tests to help delineate them. The melanoma is generally a choroidal mass. And if you look in this particular patient on this wide-angle photograph, there's a retinal detachment down below. That's not a melanoma. A melanoma can produce a retinal detachment that might very much look like the tumor, but that's a benign component. And many ophthalmologists, even good ones, will misdiagnose a melanoma as a retinal detachment before it's finally recognized. Now, how do we diagnose these? Well, we have some ancillary studies. We look in with the indirect ophthalmoscope. If we see the typical elevated pigmented mass beneath the retina, melanoma is highly likely. In many cases, however, we can substantiate the diagnosis by using tests that many of you have had done: fluorescein angiography, transillumination, ultrasound, etc. Fluorescein angiography, as you recall, is when we inject fluorescein dye into a vein and take rapid pictures. And as the fluorescein dye, which is white here but really green, flows through, you can get certain patterns that are very typical of a melanoma and will help us differentiate melanomas from other malignant or benign growths. Many of you have had ultrasound. How many people have had ultrasound done? A large proportion. It's routinely done. It's extremely important because if we see a patient with a melanoma possible, there's B-scan ultrasound that shows this dome-shaped growth with a little hollowness in it, and that's typical of a melanoma. However, in some cases, if you see this mushroom shape on the B-scan ultrasound, that's almost pathognomonic of a melanoma. You can be virtually certain it is. Now, sometimes if doctors don't have ultrasound in their office, they can do another trick, and that's called transillumination. If we take a bright light and put it beside the eye, the light will come through the eye itself and through the pupil, but it will cast this black shadow corresponding to the pigmented growth. And this transillumination for these ciliary body tumors that are hard to see for the doctor clinically really can give a lot of information. What about CT and MRI? Many patients say, well, aren't you going to do a CT on my eye or MRI because I have a melanoma in the eye? From our standpoint, it's not very useful because we can make the diagnosis with 99+% accuracy with just our other testing. However, the CT and MRI, as you know, is very important for systemic follow-up, checking the abdomen, the liver, etc. Another technique that we've developed for those that are kind of difficult cases where we're not sure if the patient has a melanoma or a metastasis or a lymphoma, we'll do fine needle aspiration biopsy. In the late 70s, we began to perfect a technique in which we could pass a needle through the front part of the eye, through the ciliary body, and direct it into the underlying tumor, draw off cells, which then with cytological examination can give us a diagnosis. And we use that every week for difficult cases where we don't quite know what it is. Here's a patient that had this growth in the iris. It didn't really look like a melanoma. It looked like something different, a benign growth, but when we did the needle biopsy, the cells were these spindle-shaped cells that are characteristic of a melanoma. So what about the clinical features? There's one other thing I'm going to address here that's very important, and many patients come in with this. Borderline lesions. You know, we talked about nevus and melanoma. And there are many cases in which many patients have a growth that we're not quite sure if it's a melanoma or a nevus. And we've devised a mnemonic that helps us recognize this. If a choroidal nevus is thicker than greater than 2 millimeters on examination, has subretinal fluid, retinal detachment, symptoms, orange pigment on the surface, and this margin near the disc, we saw that 2 fine, small ocular melanoma. And that mnemonic is present if greater 3 of these risk factors are present. There's greater than a 50% chance that that nevus is going to grow into a melanoma, and that patient needs to be monitored more closely. Carol spearheaded another study where we looked at 1,329 small melanomas, less than 3 millimeters in thickness, the real small ones, and fortunately only 3% of those small growths metastasize, so we like to catch them early. But we recognize for the first time those features that will predict metastasis from these small tumors. And we recognize these factors, and they're used in every one of our patients. If none of the risk factors are present, there's hardly a 1% chance the tumor is going to metastasize. And if all 4 of these are present, including documented growth, then there's a greater chance it's going to metastasize in the long run. And this is important because for many years in the past, ophthalmologists were taught, well, if you suspect a melanoma, just watch it and don't treat it until it grows. But we've now shown that documented growth is a risk factor for metastasis. And so therefore, we do not recommend watching small melanomas. You take them off the skin, you take out the colon lump, you take out the breast lump, but we were taught to watch these until they grow. And we now have challenged that, and that's probably wrong. Now finally, in closing, these risk factors that we talked about, we've got new techniques that are being used now, such as autofluorescence and optical coherence tomography, that we can look at certain features and we can determine which ones have these early risk factors and which small ones are going to go on to develop a melanoma. So in closing, important thing, and all of you probably have experienced this, in dealing with a patient who has uveal melanoma, and they're very apprehensive when they come in, it's extremely important to sit down with the patient and their family and spend some time talking to them about what they have. You don't say, you have a tumor, we're going to treat it, and see you later. It's important to tell them what is a uveal melanoma, what's its natural course, let them know that they can cause loss of vision, but more importantly, they can metastasize. You want to let them know about the treatment options and the expected results of those treatment options. And it takes a lot of time to spend with each patient to make sure they understand and they're properly counseled in this traumatic episode in their life. So in summary, I'm talk to you a few minutes about the diagnostic approaches to uveal melanoma and how we counsel the patients in the long run. And we hope this has been enlightening to you in a way and helpful to you when you go back to see your doctor with who sees you for a uveal melanoma. Thank you.